Over the course of this module thus far, we've explored psychological theories of aging and the normal cognitive changes that occur in later life. We examined shifts in motivation, emotional regulation, fluid and crystallized intelligence, and domain-specific changes in memory and processing speed. In our final lecture for this module, we turn to a critical distinction: the difference between normal cognitive aging and pathological cognitive aging. While some cognitive changes are expected as part of the aging process, others reflect underlying disease processes that significantly interfere with daily functioning. Understanding this distinction is essential, not only for clinical identification, but also for reducing stigma, avoiding ageist assumptions, and ensuring appropriate care. In this lecture, we will focus on how to distinguish normal cognitive aging from pathology, dementia and its major subtypes, especially Alzheimer's disease, depression and other mental health conditions in later life, and the social and structural factors that shape mental health outcomes. Let's begin by revisiting what we discussed in the previous lecture. Normal cognitive aging may involve slower processing speed, mild retrieval difficulties, such as occasionally forgetting names, needing more time to learn new information, and minor decreases in working memory capacity. Importantly, in normal aging, daily functioning remains largely intact. Individuals can live independently, and cognitive changes are gradual and stable. Pathological cognitive aging, by contrast, involves progressive decline, significant impairment in memory, reasoning, or language, interference with daily functioning, and loss of independence. One important intermediate concept is mild cognitive impairment, or MCI. MCI refers to cognitive decline that is greater than expected for age, but does not yet substantially interfere with daily life. Some individuals with MCI progress to dementia, while others remain stable or even improve. This spectrum reinforces an important point. Cognitive aging is not binary. It exists along a continuum, and early recognition matters in order to provide appropriate treatments and supports. Dementia is not a normal part of aging. It is a clinical syndrome characterized by significant cognitive decline, impairment in memory, thinking, or reasoning, and interference with daily functioning. Dementia is an umbrella term that encompasses multiple underlying diseases. Major subtypes include Alzheimer's disease, vascular dementia, Lewy body dementia, and frontotemporal dementia. While risk increases with age, dementia is not inevitable. Many individuals live into advanced age without developing dementia. From a gerontological perspective, dementia must be understood not only as a neurological condition, but as a social and relational experience, one that affects families, caregivers, and systems. Alzheimer's disease is the most common cause of dementia. It is a progressive neurodegenerative disorder characterized by the accumulation of amyloid plaques and neurofibrillary tangles. These changes disrupt communication between neurons and lead to gradual brain atrophy. In early stages, symptoms often include short-term memory loss, difficulty recalling recent conversations, and trouble finding words. In middle stages, symptoms may include increasing confusion, difficulty managing finances or medications, and disorientation in familiar environments. In later stages, symptoms advance and often include severe memory impairment, loss of ability to perform basic activities of daily living, and dependence on caregivers. It is important to emphasize that occasional forgetfulness is not Alzheimer's disease. The key distinction lies in progression and functional impairment. Alzheimer's disease also has profound emotional and social implications. It affects identity, autonomy, and relationships, reinforcing the importance of dignity-centered care. While dementia often receives the most attention, depression is one of the most common and under-recognized mental health conditions among older adults. Depression is not a normal part of aging. Symptoms may include persistent sadness, loss of interest in activities, changes in sleep or appetite, fatigue, and difficulty concentrating. However, depression in older adults may present differently than in younger individuals. It may appear as irritability, somatic complaints, withdrawal, or apathy. Depression is also strongly associated with chronic illness, pain, bereavement, social isolation, and economic stress. Research shows that older men, particularly those experiencing social isolation or chronic illness, face elevated risk of suicide. This underscores the importance of screening and early intervention. Depression can also exacerbate cognitive symptoms, sometimes mimicking dementia, a condition sometimes referred to as pseudo-dementia. This further highlights the importance of careful assessment. Anxiety disorders are also prevalent among older adults, often co-occurring with depression and medical conditions. Importantly, mental health conditions in later life frequently exist alongside physical health conditions. This comorbidity complicates diagnosis and treatment and reinforces the need for integrated care models. As highlighted in recent mental health research, collaborative and interdisciplinary approaches, combining primary care, mental health services, and social supports, show strong promise in improving outcomes for older adults. Mental health in later life is shaped not only by biology, but also by social and structural factors. Drawing from the sociological perspective on mental health, we must consider socioeconomic status, access to healthcare, racial and ethnic disparities, lifetime exposure to stress, social isolation, and ageism. The life course perspective is especially relevant here. Cumulative disadvantage across decades, including poverty, discrimination, and limited educational opportunity, can increase vulnerability to both cognitive impairment and depression in later life. Stigma also plays a significant role. Older adults may be less likely to seek mental health care due to generational attitudes towards psychological treatment. This reinforces a theme we've emphasized throughout the course. Aging outcomes are shaped by the interaction of biological processes and social structures. This discussion also invites us to revisit the concept of successful aging. If successful aging is narrowly defined as the absence of disease, then many individuals living with depression, mild cognitive impairment, or chronic illness would be excluded. However, contemporary gerontology encourages a broader understanding, one that includes adaptation, support, dignity, and quality of life, even in the presence of pathology. Mental health is central to well-being. Supporting psychological health is therefore not peripheral to successful aging, it's foundational. For healthcare administrators and professionals, distinguishing normal from pathological cognitive aging has several implications, and it may help in implementing appropriate screening protocols, avoiding dismissal of symptoms as just aging, reducing stigma around mental health treatment, designing integrated care systems, supporting caregivers, and investing in prevention and early intervention. Age-informed mental health care requires interdisciplinary collaboration and policies that recognize the complexity of later life. To conclude, normal cognitive aging involves gradual domain-specific changes that do not interfere with daily functioning. Pathological cognitive aging, including dementia and major depressive disorder, involves progressive impairment and functional decline. Understanding this distinction is essential, not only for clinical accuracy, but for ethical, equitable, and effective care. As we move forward in the course, we will continue to explore how biological, psychological, social, and structural factors interact to shape aging outcomes. As you reflect on today's lecture, consider this question. How can healthcare and social systems better distinguish between normal aging, cognitive impairment, and mental health conditions in order to promote dignity and well-being in later life? This concludes the third and final lecture for Module 3. If you have any questions about the material covered in this lecture, please contact your instructor for this course. Thanks for watching.
Only yours, you can have it. That's where I'll spend it.